de las Naciones Unidas. Este objetivo número 10 es reducir las desigualdades, pero nos centraremos en inequidades sociales en el acceso a la salud oral. El objetivo de hoy es reconocer los diferentes procesos y necesidades demográficas, políticas, sociales, éticas, religiosas, culturales, económicas y de financiamiento y otras que determinan las inequidades en salud oral. Bienvenidos todos.
Something important about the last session is that many of you were really nice to fill out the survey, and we are working really hard to improve a lot of problems that we had. One of them was the translation. So today we will have an interpretation. Interpretation is when a team of people speak at the same time that the speakers are talking, presenting their thesis. So now we have Colton Rogers, our IT director from the University of Utah School of Dentistry. He's gonna give some advice how to use the interpretation tools. So could you share your screen, please, Colton?
Absolutely. Thank you, Dr. Pinzone.
Thank you.
Okay. Well, can everybody see this now? Okay, so
Yes.
thank you. So what the plan is here is that we are going to allow for interpretation from English to Spanish as well as Spanish to English. So you will see here on this paper, this is just a quick sheet for those of you who need it in order for you to be able to use this interpretation. So what you'll do is on your Zoom screen, you should be able to go to the bottom of the screen and you will see an option where it says interpretation, like I have circled here on this paper. Now what you'll do is you'll click that button and then you are going to select the language that you want to hear the meeting in. Now what will happen is that the people presenting, their microphones will be muted for you, and you will hear the interpreter over them as they interpret the language into the language that you will understand. If someone is speaking in English and you want to hear it in English, go ahead and click that interpretation button again and select off. Or if they're speaking in Spanish and you want to hear it in English, click that interpretation button again and select English so that you'll hear it in English. And the interpretation team we have are wonderful, and they're going to do their absolute best to make sure that we hear as much as possible. So feel free to ask questions, but if you need anything, we'll all be here throughout the meeting. But again, it's pretty easy. As long as you click that button and select the language you need, it all should go well. So thank you.
Thank you, Colton. Now we're going to have Isabel Ferreto giving us an explanation of how to access this interpretation in Spanish.
Ok, no puedo compartir mi pantalla en este momento.
She's saying that she cannot share her screen, Colton. Colton, could you share the document that I sent you, maybe?
Yep, let me share it and then I can check your settings while she's
Okay. Okay, yo lo leo.
Dr. Ferreto can just read it or explain in Spanish. Could you make it bigger a little bit? Yes. A little bit more.
About as large as I can get it on this one now.
Here.
Okay, está bien. Eso está en inglés, pero se los voy a explicar en español. Estas son las instrucciones para la traducción simultánea del Seminario de Salud Global del Continente Americano. Y para todos los asistentes, ustedes pueden ver en la parte superior de la pantalla donde hay una barra. Esa barra la van a encontrar en la parte inferior de la pantalla del Zoom. En la parte derecha de esta pantalla van a encontrar una especie de globo terráqueo, que es la parte que está resaltada con rojo a la derecha de la pantalla, donde dice interpretación. Cuando ustedes ponen interpretación, tienen tres opciones. of inglés y español. De manera que si ustedes quieren oír la charla en español, nada más clican en español. Si la quieren oír en inglés, nada más clican en inglés. Y si quieren oír el audio original, por ejemplo, que estén dando la charla en español y la quieran seguir oyendo en español, nada más clican off. Eso es todo lo que tienen que hacer para oír la interpretación simultánea de las charlas.
Perfecto. Cualquier pregunta que tengan, nos la pueden enviar por el chat y les ayudaremos con respuestas. Any question you have, you can send it through the chat and we will, or question and answer, and we will answer back. Now, the next step of this seminar is that we want to learn, and we want to share some of the lessons learned from the previous session. And so I'm going to read that first in English, and then Dr. Ferretto is going to read them in Spanish. So now it starts like this. The inaugural session of our Global Health, Sustainable Development Goals and Dentistry Seminar was attended by the President of the Universidad de Antioquia and the deans of the different institutions that we have that have participated in this seminar to date. The words of these authorities show their interest in getting involved in this reflection on how dentistry, other areas of health and social sciences can contribute to the achievement of the objectives of sustainable development. Even when there are no oral health indicators in the goals of the health objective. The academic and solidarity activity and the opportunity of different approaches to experiences will surely be productive. As dental professionals, we should ask what the United Nations Sustainable Development Goals are, what the 2030 Agenda is, and what are we doing to contribute to the achievement of the proposed goals. There are 17 goals, and the 2030 Agenda is an alliance of the United Nations where the 193 countries agreed to participate. The United Nations works as a managing entity. This universal agenda is focused on people, the planet, peace, prosperity, and alliances. Alliances are a tool to carry out the objectives without underestimating other approaches. We are invited to assess the definition of development that drives the United Nations Sustainable Development Goals in following sessions. Now, Dr. Cohen shared with us the story of the creation of the health arm of the United Nations after the World War II. The World Health Organization has the aim of providing normative guidance to member states to rebuild or strengthen infrastructure for the health of its population. She also spoke about the creation of the National Institute of Dental Research. These entities recognize that the health of the population was a basic and essential need to enable the economic and social development of any nation. The collaboration between these two entities continued for decades and included research projects with the World Health Organization, Regional Office for the Americas, the Pan American Health Organization, located in Washington, D.C. More recently, the United Nations General Assembly approved two major declarations, both of which explicitly include oral health. The September 2011 declaration deals with the prevention and control of non-communicable diseases, and the September 2019 declaration focuses on universal health coverage. The second declaration on universal health coverage is also considered essential for the SDGs 3 on health. The inclusion of oral health under this umbrella of financial protection signals a step towards significant progress that could occur in integrating oral health into primary health care. In conjunction with these two global efforts, the governments, by governments, the Lancet published for the first time, a series of articles on global burden of oral disease and contributions and the issues related to addressing those burdens. That issue was published in July 2019, and after its release on July 24th, the Lancet Commission on Oral Health was announced. That body is co-chaired by Professor Richard Watt of University College London and Professor Carol Cristina Guarnizo Herrera of the National Universidad of Antioquia, la Universidad Nacional de Colombia, who is one of our guests at today's seminar. This is a work in progress, and today we will learn more about it. Dr. Beltran, a representative of the United Nations, introduced us to the way of working in the United Nations, especially in her area of work, and invited us to find out in each of our countries which local agencies are coordinated and the global indicators that they are developing. This is important because in each country there might be different prioritized goals and different trajectories. There are national and international sustainable development goals. These agencies generate indicators for the statistical results, but it's necessary to determine what the sources of information are. Some questions to ask from academia, private companies, non-governmental organizations, and public agencies are the projects that can accelerate the goals and how each country contributes without leaving the selected goals. Dr. Abadia made a critical analysis of one of the goals of the health and wellness objective. Target 3.8 is achieve universal health coverage, in particular protection against financial risk, access to quality essential health services, and access to medicine and vaccines that are safe, effective, and affordable for all. The use of universal health coverage indicates that it has been criticized by researchers from different countries because it changes the logic of universal health care to a language of coverage, which would allow the selection of packages of services for certain population groups and under a restriction of limited resources, while the rest not covered would depend on the subside networks of market networks. This can also lead to negative consequences such as flexible work and precarious work in health. Basically, the logic of universal health coverage would not be on the same path as the aspired right to health, as stated in Alma Ata. Health should be a right and not a commodity. Universal health coverage is the antithesis of right to health. In summary, the current oral health landscape seems to point to bright spots for constructive change to to realign dental services, the education of the health professions to provide those services and the coverage of both preventive and treatment services with the oral health needs of populations on the receiving end. Incentives for integration into primary health care and for a collaborative whole of society approach to addressing the social determinants of health and disease are beginning to be present. It seems fitting and appropriate that the Americas can accelerate the process through regional collaboration. Now, Isabel, you want to continue? Thank you.
Yeah, gracias. Les agradecemos su asistencia y queremos contextualizar las lecciones aprendidas en la sesión anterior. Les recordamos que la traducción simultánea se activará, se dará por iniciada con los panelistas. Todo lo que acaban de oír de la doctora Pinzón van a oírlo ahora en español. Las lecciones aprendidas las queremos recordar para todas las personas que no nos pudieron acompañar en la primera sesión. Así que estas son las lecciones aprendidas de la primera sesión de nuestro Seminario de Salud Global del Continente Americano, que fue en el mes pasado. La sesión inaugural de nuestro Seminario de Salud Global, ODS y Odontología, contó con la participación del rector de la Universidad de Antioquia y con los decanos de las diferentes instituciones participantes hasta la fecha en este seminario. Las palabras de estas autoridades, rectores y decanos muestran el interés en involucrarse en esta reflexión sobre cómo desde la odontología y otras áreas de salud y de las ciencias sociales podemos contribuir al logro de los objetivos de desarrollo sostenible, aún cuando no existen indicaciones de salud oral en las metas del objetivo de salud. La actividad académica y solidaria y la oportunidad de diferentes enfoques de experiencias seguro serán una actividad productiva. Como profesionales de la odontología, lo primero que hay que preguntarse es ¿qué son los Objetivos de Desarrollo Sostenible de las Naciones Unidas? ¿Qué es la Agenda 2030 y qué estamos haciendo para aportar al logro de las metas propuestas? Conocer cuáles son los 17 objetivos y entender que la Agenda 2030 es una alianza de las Naciones Unidas donde participan los países que las suscribieron, siendo un compromiso en 193 países que participan y donde las Naciones Unidas funcionan como un ente que gestiona. Entender que esta agenda universal está enfocada en las personas, el planeta, la paz, la prosperidad y las alianzas, siendo esta última una gran herramienta para llevar a cabo los objetivos sin menospreciar los otros enfoques. Algunos comentarios que nos invitan a retomar en las siguientes sesiones son cómo evaluamos la definición de desarrollo que impulsan los objetivos de desarrollo sostenible de las Naciones Unidas. La doctora Cohen en nuestra primera sesión compartió con nosotros la historia de la creación del brazo de salud de las Naciones Unidas después de la Segunda Guerra Mundial, llamado Organización Mundial de la Salud, lo que conocemos como OMS, con el objetivo de brindar orientación normativa a los Estados miembros para reconstruir o fortalecer la infraestructura para la salud de su población. También nos habló la doctora Cohen sobre la creación del Instituto Nacional de Investigación Dental. Estas entidades reconocieron que la salud de la población era una necesidad básica e imprescindible para posibilitar el desarrollo económico y social de cualquier nación. La colaboración entre las dos entidades continuó durante décadas e incluyó proyectos de investigación con la Oficina Regional de la Organización Mundial de la Salud para las Américas, la Organización Panamericana de la Salud, ubicada en Washington, D.C. Más recientemente, la Asamblea General de las Naciones Unidas aprobó 2 declaraciones importantes, las cuales incluían explícitamente la salud bucal. En septiembre del 2011, que trata sobre la prevención y el control de las enfermedades no transmisibles, y en septiembre del 2019, centrado en la cobertura universal de la salud. La segunda declaración sobre la cobertura universal en la salud también se considera esencial para el ODS número 3 sobre la salud. La inclusión de la salud bucodental bajo este paraguas de protección financiera señala un paso hacia un progreso más significativo que podría ocurrir para integrar la salud bucodental en la atención primaria de salud. Junto con estos dos esfuerzos globales de los gobiernos, la revista Lancet publicó por primera vez una serie de artículos sobre la carga mundial de enfermedades y infecciones orales y los problemas relacionados con el abordaje de estas cargas. Ese número se publicó en julio del 2019 y, posteriormente, después de su lanzamiento el 24 de julio, se anunció la Comisión Lancet sobre la salud bucal. Este organismo está copresidido por el profesor Richard Watt de la del University College of London y la profesora Carol Cristina Guarnizo Herrera de la Universidad Nacional de Colombia, quien es una de nuestras invitadas en el seminario de hoy. Este es un trabajo en progreso y hoy aprendemos más sobre. La doctora Beltrán, representante de las Naciones Unidas, nos presentó la forma de trabajo de las Naciones Unidas, especialmente en su área de trabajo, y nos invita a conocer en cada uno de nuestros países cuáles son las agendas locales que están coordinando los indicadores globales que están desarrollando. Esto porque en cada país puede existir diferentes metas priorizadas y diferentes trayectorias. Existen objetivos de desarrollo sostenibles nacionales y objetivos de desarrollo sostenibles nacionales internacionales. Las agendas generan indicadores para resultados estadísticos y se requiere hacer la búsqueda donde están las fuentes de información. Algunas preguntas para colaborar desde la academia, empresas privadas, organizaciones no gubernamentales y organismos públicos son los proyectos que pueden acelerar estas metas y cómo se contribuye sin salirse de las metas seleccionadas en cada país. Finalmente, el doctor Abadía realiza un análisis crítico a una de las metas del Objetivo de Salud y Bienestar, la meta 3.8 del Objetivo 3. Se refiere a la cobertura universal de salud. Lograr la cobertura universal de salud en particular para la protección contra los riesgos financieros, el acceso a servicios de salud esenciales de calidad y acceso a medicamentos y vacunas seguros, eficaces, asequibles y de calidad para todos. El uso del lenguaje cobertura universal en salud señala que ha sido criticado por los investigadores de diferentes países debido a que cambia desde la lógica que los cuidados universales de salud a un lenguaje de cobertura, la cual permitiría la sección de paquetes de servicios para ciertos grupos de población y bajo una restricción de limitación de recursos, otorgando atenciones mínimas. Mientras que el resto, no cubierto, dependería de las redes de subsidios o de las redes del mercado. Esto además puede conllevar consecuencias negativas como flexibilización del trabajo y trabajo precario en salud. En el fondo, la lógica de la cobertura universal de salud no estaría en el mismo camino del aspirado derecho de salud como quedó consignado en el Alma Ata. La salud debería ser un derecho y no una mercancía. La cobertura universal en salud es la antítesis al derecho de salud. En resumen, el panorama actual de la salud bucodental parece señalar puntos brillantes para un cambio constructivo para realinear los servicios dentales, la educación de los profesionales en salud para brindar bien estos servicios, la cobertura de estos servicios tanto preventivos como el tratamiento con las necesidades de salud bucodental de las poblaciones en el lado receptor. Los incentivos para la integración de la atención primaria de salud y para un enfoque colaborativo de toda la sociedad para abordar los determinantes sociales de la salud y la enfermedad están comenzando a estar presentes. Parece adecuado y apropiado que las Américas puedan acelerar los procesos a través de la colaboración regional. Lili.
Hi. Hi, okay, so now we're gonna start the interpretation. And please activate the simultaneous translation. If you have any questions about that, please follow the steps provided in the chat in Spanish and English. Two people are gonna be helping us with that. And so welcome Dr. Hume. He's the Dean of our School of Dentistry here at the University of Utah. He's gonna give us some short remarks. Welcome, Dr. Hume.
Thank you, Dr. Pinzon, and Dr. Alvarez, thank you so much for doing this wonderful thing together. The American Continent Global Health Seminar is a fabulous thing to do, and I'm delighted that the University of Utah is part of it. I'm hoping that this is a good test of the translation or the simultaneous translation, and if somebody can put into the chat that it's working, I'll be very relieved. I speak first of all.
Primeramente, les doy bienvenidas y gracias por parte del Dr. Good, quien es el
University of Utah, and from our president, both of whom I've talked to about this. Both are excited that it's being done and express their gratitude to all of you as well. I got together with Dr. Pinzon about a week ago to talk about what would she like me to say in these brief remarks. And I asked her the question, what is it that everybody who's joining, almost 200 people are joining, what do they want from this seminar? And Dr. Pinzon gave me a very simple but a very powerful answer. She said, everybody wants programs for all of our universities so that all of our students and faculty can learn to come together to do effective clinical care research. And I think that's a wonderful thing to do. And so the topics that will be covered will embrace public health, global health, statistics, epidemiology, clinical and translational research, all of great, great value. And when I heard that, I thought, what is it that we at the University of Utah can contribute? Of course, we have the fabulous talents of Dr. Pinzon, who's got a very strong track record in those areas. So she will be an asset to you all. The university itself, the university's dental school is young. It was only conceived really 10 years ago. We've graduated 4 classes so far. We're about to graduate our 5th. But we have decided as our strategic goal that we will study the outcomes of care, in particular, the influence of oral health interventions, not only on oral health, but on health overall. And I was interested to hear in earlier remarks, the integration of oral health into overall health has to be part of our goals. As you can see, I'm not a young man. I've been in public health dentistry and dentistry for more than 50 years. And it's been a fascinating journey trying to improve the oral health of populations, often in isolation from the remainder of healthcare. And I believe deeply that is not our future. I believe very strongly that our future will be working with our colleagues in all other aspects of healthcare, everything from psychiatry to the diabetes treatment, to the care of mothers and children and of pregnant women. Everything we know about oral health gives us strong indications that improving oral health will improve all of those chronic conditions that afflict humankind. And I believe that our institution has a responsibility to do as much as we can to demonstrate those effects so that we can get the best possible outcomes of care for populations at the most reasonable cost to individuals, to families, to communities, and to societies. So bless you for what you're doing. Thank you very much, everybody, for coming together. Thank you, Colton, for your great work with this platform, and I've noticed in the Zoom that the translation is working. So thank you very much, everybody. I look forward very much to this evening and to future months of seminar activity. Dr. Pinzon, thank you. Back over to you.
Thank you so much, Dr. Hume, and thank you so much to Kina's team, Roberto, Yesenia, and Colton, and Geoffrey. and I forgot what's the name of the other person that from the communications team. They did a great job. We're very excited to have this simultaneous interpretation. The following three presentations are gonna be in Spanish. So please activate the interpretation that you need, and you have any questions, just let us know through the chat. So I'm gonna leave you Isabel to introduce them. You're mute.
Ok, listo. Gracias al Dr. Hume por sus palabras.
Thank you to Dr. Hugh for their presentations. The next 3 presentations will be in Spanish. So please activate simultaneous translation if you need it. If you have any questions, please follow the steps that you will find in the chat of this platform in Spanish and English. Also remember to complete the satisfaction survey. We need your opinion and to improve this wonderful experience. Now to start, we will give our first welcome to our first panelist, Dr. Carol Guarnizo Herreño, dentist and master in public health sciences from the National University of Columbia, with a PhD in public health from the University College London, teacher and researcher at the National University of Columbia, co-chair of the Lancet's Commission on Oral Health. Her research interests include social inequities in oral health and social determinants of health. She has several scientific publications and has been a recipient of scholarships from the National University, Fulbright, University College London, and the Newton Fund. She is currently a teacher and researcher at the Faculty of Dentistry at the National University of Columbia. Carol herself is also an honorary senior research fellow in the Department of Epidemiology and Public Health at the University College London. Prior to her academic career, she worked at the National Institute of Health of Colombia and at the Secretary of Health of Bogota. So now we welcome Dr. Guarnizo. Thank you, Isabel, for the introduction. Thank you very much for all of you, the organizers, to have me being here with you guys and speaking. Dr. Alvarez, Dr. Lily Bunson, and well, very happy to be here with you all. So now I will start with my presentation. You will see it here on the screen. And I'm hoping that we will be able to start ahead. Let's see if you can see my screen. There we go. Well, we're going to share with you a presentation that we will now be here for with the seminar, which is the inequities of the oral health. And I'm going to start with this panel, some reflections, some conceptual reflections, and also some ideas, some challenges for the action to be able to diminish all of this information. The next section will be in regards to the seminar. There will be some points in there, but basically, we're gonna start with you some sharing the concept of inequities in oral health. But you're also gonna notice that my presentation, it'll be very socioeconomic, and these are not the only ones, but also in the previous interventions, we've also done a lot of dimensions of inequity, ethnic, sexual orientation, all those issues. But I'm going to do a couple of emphasis on these relationships between them, between the people and the collections as well. We know, as you can all tell, it's very super consistent, and it's very big at a global level, with this consistent between the socioeconomics and the global and the oral health. We're going to converse in the existence of why there is that relationship, the mechanisms or the roads in between the two, the relationship. And then also, like I said, at the very end, we're going to do the actions of public health, of what to do, or of what we need to think is necessary to be able to start these in regards to inequity. So we're going to talk a little bit in regards to what we speak about or what we're talking about when it comes to socioeconomics inequities in health. What are the differences between the groups or the different populations, especially with the positions and the socioeconomic, the inequities when they have these characteristics. Systematics, their injustice, they're inevitable, and they also are observed between the groups of community with different levels of richness or prestiginess or power as well. No, it's not something that's natural. There is nothing that you can do. The populations are just like that. That's our destiny. It's just what we're doing and how we are. And also from the point of view of the socioeconomic is also the differences. Something really important here to mention is that these differences do not exist only between social groups of a very high or very low, but they also exist. So it's not only a theme between the rich and the poor, but it's also these inequities are found alongside all of the different social hierarchies in regards to the gradients of the social in health. So now we are going to see some examples of those, and especially those of the social health. So this presentation, this model here shows the determinants, the social determinants of oral health that I was talking about earlier, especially when it comes to the determinants, to the social determinants, excuse me, that you can also go down that they are transmitted. This upper portion is very well known in the conceptual socioeconomic structures. So right here in the determinants are the structural determinants with indecision to the public, economical, and environmental as well, the interchangeable of them. But then those also go over.
Ay, vale, bueno, lo sospechaba. Sí, listo, gracias. Claro, Gloria. No, a ti gracias, perfecto. Bueno, voy a prometo ser juiciosa. Voy a hablar más despacio.
I will try to speak slower. So I was telling you then that these policies right here, these determinants, the structural determinants are actually determining the difference or the organizations that are distinct into the social positions, but they are different in regards to the focus that they have, the governments, and then also as well our rules and our policies. And so then the social areas where they be more equity or equal in the hierarchy and more stronger. Because as you know, the social questions like the diversity, if they're universal, or if they're assigned the social determinants, they will mark what is the natural wave of everything of the societies. And so that will also cause with the social positions and the circumstances depending on their social class. So like their education level, their gender, their ethnicity, their income, social class, all of that. But that at the same time will determine what is their positions that they live in, where they work at, what they do in their free time, their studies. But it also will have to do with these different mechanisms right here that we will be talking about much more in our presentation, like the material circumstances, psychosocial factors. But now these are the ones that are closest to us when it comes to the oral health. And this figure right here, which we have the determinants, the proximal determinants or the behavioral ones. In the very end, these are the biological of manifestation of the dynamic of all of this, starting from the context of structural determinants, but even besides this, the mark of conceptualism, which is this number right here, which is the oral health, which added to this, the commercial determinants. So it combined with the corporate strategics, which is also the determinants of social structure, education. And so with that, this has caused it to be able to be more unified to all of the strategies that are being used by all corporate, multinational, the private and public sector to promote their products and also to help increase their sales and all of that as well. But also do the products that impact them as well. So here you can see what they are wanting to do. What they propose is the political, but how is it that they separate themselves, the dynamic that they have in regards to social health. So understanding all of that, and especially the origin of these inequities of this oral health, is in regards to those arrangements with which we have spoken about. It is very specific to our context that we understand the challenges, the particular challenges within our context. So as you can tell, we are very equitable in regards to all of America in itself. But we have groups of communities or population that are systematically marginalized. But it's very predetermined that they are as well. And within this context, that they have the corruption, they have high levels of corruption, but also rendition or keeping in check everyone that has what they're doing in the process in our countries. But it's also in regards only to our health systems that are monetized or that are fragmented as well. So this right here will demonstrate an example of an informant of that will show this is an indicator that is the generations of the mobility of from 10% to the inferior income of this middle class to that of the higher class. So here we can see that you can see the different societies, different countries that do that as well. So Colombia is over here on this side, which it's one of the countries that is very inequality. And so now we need 11 generations to be able to go from the 10% of the inferior income to that of a middle class. This is a very dramatic inequalities, social inequalities. And as you can tell, the socioeconomic inequalities of birth. But this is an example. It's not in regards to oral health, but I do want to tell you that this is the inequalities of birth, which also mark the public health strategics. And we also know that they are in their development in regards to their coming of age. This is a country analysis in Colombia that is doing that of 11-year period of 11 years that will do it. And this graphic demonstrates the relative index of inequality on this line. And then on this other show, it shows that here there was no change whatsoever. It's all the same. But then the care by maternal education level. But also analyzing that there are other items that they're also checking and making sure that are included in this study for inequality, which is contrary to what we are observing in minimum, which, as you can tell, it's very worrisome, dramatic, and it does call our attention to the state of the inequalities that exist in our countries, which is very popular in our demand in this area in regards to the socioeconomic of the community. for in this case, it would be the cavities, which is the revision systematic of cavities, in which we will be able to help out with this. It's higher risk of cavities for the people that are with a lower education level, but a lower occupational level, and then also minor incomes, or those that are like the properties of or the origin of family. As you can tell in the revision on this side, it's the risk is also. But this one is in regards to an interesting analysis that was done in one of the previous studies that will show the education, and then also those that to have the teeth, 3 or more teeth with cavities that have not been treated as well. I always tell my students that these graphics are made for those that are in those classes of gradients, because it tells you exactly that the first one is right here at the education level, and then how it jumps up from one to the other, depending on how less of a education you have. So it's more prevalent when you go down in education. However, in the area with the PSE of the area, so this one right here, as you can tell, it goes down. This is what we use in Colombia, which is the stratus. And this is how we detect this public service and the education and the achievement that they have in the area that you live in. And as you can tell, highest, middle, low, and then lowest. And so the lower you go in the socioeconomic, the area that it's in. But then when you have the insurance of health, so the health insurance, as you can tell, exceptional, contributory, and then depending on the formal education you have or work, will depend on this. So this of the exceptional will be some of the groups like police, like the police, the public sector, government, all of that. And then contributory, this is the rest of the population. The one where it's subsidized is people that don't have formal jobs, that are characterized as or classified as poor, which are instrumental too. And then this one, the non-insured. So the ones that don't have insurance or anything like the qualities that everyone else has. But then as you can tell also right here, the graphic. But then this one is the next, which is the income, which is less than half of a minimal salaries here on your far right. And then your highest one, which is greater than there, for those that are being treated. The majority of the evidence that we have about the socioeconomic and oral health inequities that we have is coming from the national studies. That is where we come and have the most of the information. But we also have the evidence here that will show this. Like this is an example. This is very interesting, is the ball one. This one, this study is particular, that this trend right here of income very low or variable during the cycle of life, that will increase prevalence of periodontitis, moderated or severe, with between the 31 years. And it has increased, as you can tell, and from here to here, which is the biggest prevalence, as you can tell, which is either moderated or severe at 31 years of age, which is the reason for this analysis. And then this evidence also doesn't, it shows that it doesn't matter what in this moment, what it is that your socioeconomic status is, because now you're able to help with the socioeconomic during the time frame of your life in regards to that, in the perspective of someone else. Something also that helps with this, and during our Lancet series of oral health, is the inequities or the extreme inequities that we have. On the left here, you can tell that you can see that there's a huge jump from here to here that is an extreme, but it defines as the different inequalities that affect to those communities that are very marginalized, that are very low. So like those that are against their will of being held like prisoners, or the communities that are ethnic minority, Native Americans. So these are all the extreme inequities that cause that difference of the socioeconomic ability to be able to go. But you also need to be able to study them and read from them and learn from them, because normally they aren't included in these national studies that we have. This is just an infographic that is from the Lancet, which is their infographic that they talk about to be able to start off their extreme oral health project that they were doing, their series that they have on oral health. So in these minutes, we're going to speed up a little bit because I'm conscious of the time, but I think this is very interesting and why there is there's a relationship between the socioeconomic conditions and the oral health. And so in the literature, it is proposed that it says to answer that question is the materialistic mechanism is the first to answer that question. This mechanism is referred to as the direct effect over the oral health of the condition of the material conditions of life and work, and also the material resources that are available to access, like the food, the homes, and services. And under this mechanism, you also would say that the income affects the health for which they are having the difference, which means that the money affects it and affects the resources that they have, or the access to resources that they have is affected by the currency or the money they're being paid, because it's very important for the health, like the food, making sure they have enough good quality of food, but also the quality of living and helping out with all of that services of health. The second one is the psychosocial mechanism, which is centers their attention in the real life or in life, in general life. It's a very complex, but the mechanism is helping to equate into all of the other necessities that we have with the mechanisms. The psychosocial mechanism, it centers its attention in the difference that exists between groups, socioeconomic groups, and factors, psychosocial, which include the experience of stress. And here we mean that the high levels of stress, which is that of the socioeconomics. But this doesn't also mean that it talks about their stress at an easier level or a higher level, but it also means that their socioeconomic statuses that causes their high levels of stress, which means that they have little control in their work, they're unemployed, they're low in their PSEs, they live in communities that are under low levels of confidence or high levels of crime or insecurity as well. And so when I mention this, it's because, yeah, like, yes, I understand, like, very low, but it's also with our society. These low income communities are also those that want to become more characterized with the high level of crime and insecurity. And they have that generational aspect of it. But these also will affect the health, and also because of direct paths and indirect paths with the psychosocial mechanism. And this results in a deterioration of the health, but also with the indirects, it also comes in with their influence of their behaviors, like smoking. And then this last one is the behavioral mechanism. And this one has everything to do with everything that we just talked about, the factors and also the materials factors. But this one centers its attention in the differences that exist between the groups, the socioeconomic groups, in behavioral relationships with this health, like that of the eating, the smoking, physical activity, and then also the consumption of alcohol. Something that is very important to mention here is that to be able to change the behavior, we need to change the surroundings as well. Making sure that they brush their teeth, that they're eating healthy foods, and that they're also doing their oral health as well. We have been doing this for quite a few years. It's not reasonable to wait that the people change their behavior when in reality, the easiest thing to do is to change the context, the social context. Since the human body and the human in and of itself is very complex, all of the social, psychosocial compartments can be changed, not with being voluntary, but being able to told. The last thing that we can do is the mechanism. It's not a mechanism, but it's more just to kind of see what the perspective is of the course of life. This is what we mentioned earlier when we talked about the study's results of CORE, is that the status of health at whatever age is the result not only of the conditions of the socioeconomic conditions of that moment, but also to the conditions of the previous life, which is of what happened before you were born. So in regards to that, just remember that that is also because of that. And then with the inequities of health, it has resulted that the inequities in the accumulation of goods and bads as well. I'm going to do this part really fast because I'm almost done, because I know that the next session is going to be more directed to this, which is the actions of public health, and then also the impact over inequalities. So we also have revisions, which will show that actions, even if they're well-intentioned, even if they are just to be able to provide information directed to the communities, for example, like massive media of communication, they assume a homogeneity in between those that are recepting it, but they also are very appropriate for those of the higher level education, which means more education and more income. But then the interventions over the conditions of life and or work or the physical medias will cost the taxes to healthy foods and beverages and or health in Mexico. And this is an example of that, of a study that was published with the dates in Mexico with the heredity. But we used to have a lot of models in regards to this. But this one is just empirical results of the oral health in Mexico, also the temporary health as well. As you all know, we have the emphasis on media preventative clinics, and then also in short terms and long terms, which also can be a potential to increase. And here is where we can show and make us think about what the importance of these actions are in regards to the determinants of the conditions of the oral health. These are giving us great opportunities to be able to share these different conditions and risks with you guys. To close now, I think it's worth it to mention, I guess, the pandemic, the COVID-19 pandemic that has magnified the inequities previously existing, but also creating new ones, and that they have been very dramatic in realizing the connection between both. But it's also been able to help show us that there is inequity in diseases not transmittable, and also the determinants of social health, but also causing the probability of those around us that can cause them to have very limited access to oral health as well. A lot of people had to work, or that they weren't able to do unemployment, and so they had to continue. And so this has caused them to also not know what to do with the oral health and have them be able to do that. This also has caused them to have severe consequences to the economic crisis because of it. But it also has caused that the pandemic has significantly affected the populations that have been having a limited access to the oral health attention, which without a doubt has aggravated the already dramatic inequities. Very well. So I talked about the Lancet Commission on oral health, which I wasn't able to do now, but here is a preview of them with their key priorities, which is one of their 4 equities is right here. Specifically this one, which talks about the equity in the social justice and oral health. And so we're working on that right now. Very strong. And that helps with what we're talking about tonight. I'm sorry that I went over a little bit, but I just wanted to show you about that. And I wanted just to talk about this really fast as well. That all of these struggles are reflections of those that we have been able to do of the global health as well. And right here now we're talking about, as you can tell, a reference to Richard Horton that he mentioned in the slide editor in the first recording of their more communicable magazine, which, as you can tell, that it's very needed. It's very open. It's ensured to please keep your stories going, mobilize your civil society, and then make the evidence work for your use as well. Because we understand that oral health is not better. It's getting better, but it's not best. And so we're trying to find resolutions for that as well, and all of these dynamics. And we want to give you guys an opportunity to be able to take advantage of that. Well, with this, I close. Thank you so very much. And thank you very much.
Gracias a la doctora Guarnizo por su presentación.
Thank you, Dr. Guarnizo, for your presentation.
Hola Isabel, creí que te tocaba a ti la próxima.
No, sí me toca, pero no sé si querías decir algo, doctora.
No,
I don't know if you wanted to say something to the doctor, but thank you so very much. A very excellent presentation. It is very accurate to the section that we're doing.
And is the best way to start this topic. Isabel.
Sí. Bien, les recordamos que pueden hacer sus preguntas a través del chat.
Well, we remind you that you're able to make your questions in regards to chat. And then at the very end, we'll have about 15 minutes to be able to help with the questions and answer. Now we will continue to our next presentation, which also will be in Spanish. Again, like I said, we remind you that you're able to activate the simultaneous translation. And then if you have any questions, please put them in the chat. And then also remember to complete the satisfaction survey because we need your opinion to make sure that we're improving these experiences for you. In continuation, we were going to now listen to Dr. Iris Lucia Espinosa Santander. The Dr. Espinosa is a dentist surgeon, specializing in pathology and oral pathology, master's in science of odontology, and also doctor in public health in the University of Chile. She is also a associate professor in the Faculty of Odontology of the University of Chile, as well as a researcher in the Center of Epidemiology and the Vigilancia of this diseases orales or orals with their initials in SEVO in Spanish, and also with the Center of Inter-University of Geriatric Health, CIES, but also the director of the Strategic of Odontology of the Oral Pathology Unit of the Hospital Digital of the Masters of Salud of Health in Chile. But this Dr. Iris will now talk to us about the next presentation called "Is the Oral Health an Aspect that has been forgotten in the SDGs, and how do we become involved?" Again, we want to welcome Dr. Iris, and we appreciate her collaboration and having her.
Thank you so much for the presentation.
Thank you
Does
very
everyone
much
hear
for
me?
your
Perfect.
presentation and for that as well.
Thank you. I'm going to share my screen.
Share my screen. Can you see this
it,
now?
Raul?
Well, thank you.
Good
Welcome
evening
to all of you
everyone.
guys. I appreciate it, first of all, the
I want
invitation to
thank you for the
to
thank
Dr.
Dr.
Gloria
Oliver
Alvarez and to Dr. Lily Pinto
Pinson
and to all of the academic
invitation
universities that have been involved
in this
in this.
conference.
And to all of you that are present here, I welcome you. Well, like we have mentioned, this presentation will be talking about the inequities but we're going to be talking about the SDGs, the reduction of the inequalities, as well as the fight against the climatic changes. As you have noticed, we have been able to realize that there are 17 objectives or goals for our sustainable development within the United Nations. And it's very important that they are very integral as well as transversal. And if they better those aspects of life, then they will also better the oral health. Objective number 3 or goal number 3, which guarantees the good health lifestyle, as well as promote the lifestyle for all and all of the ages. But without ado, and we are able to define all 3 of those goals that we have in the sub goals of them. We don't have one that is very specific of these different diseases. And these, what they're due to is the fact that the problem health of the oral health, is that they are not observed, indicated in impact of specific oral diseases. Right now, what it's missing is that we are not fighting for them or advocating for them from the odontology area, which are the more basic problems in regards to these. One of the points that I want to bring your attention to is the aspect of the advocacy part that we are missing. A couple years ago, we did a revision in regards to which countries in Latin America have history in these ranges from 2000 to 2015 of the surveys that would be able to survey or evaluate the oral health in adults. And during all of the Central and South America, there's only 5 countries that had developed these surveys that would evaluate the oral health. Therefore, these surveys were designed specifically for the measuring of oral health, but there are very low cases of surveys for that in regards to oral health. In Brazil, it's very important that we have the information to have that information so that we're able to provide that information to those that are in regards to that. The other point is that the oral health has been demoralized in a sense because they haven't been able to focus on it. Periodontal disease as well, which is also the focalization of what is actually going on in the oral health aspect. Also, these factors include what is the smiling of it, as well as their vocal expression, their facial expressions, the smelling, tasting as well. And it's very hard to be able to separate those different areas of the mouth and of the oral health as well because of that. Speaking with the director Pinzon, we thought it was very well to be able to share these different items of what the oral diseases of epidemiologists that exist here as well. And also to remember that all of the story of diseases of oral health come through from birth to with very high impacts with social as well, but then they advance throughout their ages as they're growing, as well as those with that are adult. And then it also goes up to those that are adult, which is 54% of those that are that's 12 years old. And then with cancer as well could come as from that aspect as well. Going up to
para facilitar la traducción. Disculpa y muchas gracias.
Sí. Gracias por recordar. Además de esta situación de los problemas dentales,
more about this dental situation and all the problems that we have, the impact that these dental problems have, more than anything is self-esteem, more than anything the social stigma. For example, you can see with the loss of teeth,
abandonment in that sense. that
can say
social
this
abandonment is
leaves
more during the
older
elder
people
population because of their dental
these dental parts.
mouth being gone. But it's
Algunos vínculos entre la salud general y la salud oral. La salud bucal tiene una relación
Some other things
con la salud general ya determinada
with general health,
varias enfermedades. La más importante
they're determined with different sicknesses. More than anything, with the relationship with diabetic people. And other things too is pneumonia, but other things that you can see this manifested in the mouths of or manifestations of AIDS in different areas of the world, especially in more tropical or subtropical areas. We found different unique illnesses of that area. For example, those usually show up first. Dental cavities, they're not only the more usual problems, but also more prevalent problems. Like 35% of the population is affected. And what makes us worry about this? And this is what connects us with
enfermedades orales y el mejor.
Un momentico, por favor, que es que están, hay un problemita con el intérprete. Ya estás conectado, Roberto. Hola.
Hola, ¿ya está conectado?
Roberto, are you connected?
Here, one moment.
Yesenia.
Un segundito, por favor. Disculpa, Iris, es que doctora
Lo
Iris.
siento, I'm sorry. I'm good. We can go now.
¿En dónde iba? ¿Hasta dónde tradujiste? ¿Pudiste traducir, Yesenia, más o menos? Para decir.
La última pantalla.
Tomemos un pauso, entonces no sé hasta dónde llegó Roberto, pero si quiere empezar de este objetivo, yo puedo empezar de allí. Lo siento.
Ok. Okay, entonces continuamos.
Sí, por favor.
Ok. Y, doctora, puedes continuar. Gracias.
Bueno, disculpen, primera vez que estoy en una presentación.
I apologize. This is the first time that I'm in a presentation that I have to use interpreters. So I was commenting on here the oral health with the social gradients that are similar because of the inequalities of social health, but also determinate the gradients of the oral health as well. Here you can tell that it observes not only the periodontist, but also the perceived oral health. But also you can see the perceived general health right here, and then the ischemic heart diseases right here. But it doesn't show that the oral health has a lot of similarities that are observed with the general population as well. These inequalities, socioeconomic, do not affect only the countries that are the poorest, but also it also affects the countries that are the richest or that have better, higher resources when it comes to their communities, as in Australia and Vietnam. But as you can tell, the prevalence right here is higher in regards to their groups with socioeconomic standings in comparison right here to Australia that you can see as well. These are comparisons of the two countries. Now, as we were commenting in regards to Chile, these are the average number of education in regards to the years that they have. So on the bottom, it's the years of education. And then on the other side, it was the average of the teeth that were remained. So this one is showing you the difference between the average of the teeth with the lowest and the highest as well, with social economics and the high, low, and medium. These inequalities are more marked when it comes to the adults, because with the adults, they have accumulated the effects of what is the less access to the oral health doctors, but also it shows their socioeconomic status as well. The inequalities in the number of teeth that remain are higher in the individuals of 45 years and older in comparison to the group of adults that are between 21 and 44. A problem that is distinctive, that is indicating here with the oral health, is the uncomfortableness of when they talk to others, or the pain and sufferment, or the uncomfortness that they feel when they're in front of others, or the interference between activities of daily living. So as you can tell, 18.8% have the uncomfortableness of being able to speak with someone else. Right here, we are studying that these issues to talk, or the not being able to eat, is not also due to the dental problems, but also to the loss of teeth, and then also cavities. So the biggest item that we see on here is that their inequalities impact negatively to the quality of life and relationship with the oral health, which is evident in the Chilean adults when the position or the socioeconomic position is represented on the level of education, and it will stay the same afterwards. Other data that I want to be able to share with you guys in regards to oral health is with the association of the populations that are indigenous communities, and being the Mapuche tribe, which is the most prominent of it all. And this one is a lot of mestizaje, or mixture of cultures and backgrounds. But within all of this as well, you can see the level of cavities that are in the boys and girls that are originally of 49%, but also not of the 39.73. These are also in regards to the numbers of everyone that has entered school, with looking at their oral mouth as well. And these results, you can tell that all the ethnic groups have a prevalence to the cavities in regards to the non-ethnic groups that are not part of the originary communities as well. So Quechua, Amara, these are northern Chilean areas of the country. And then they also share with what is the northern areas of Argentina and Peru, which also come from this same ethnicity. When you can tell that there are these areas with the Latin American area, that there is very little studies, but you can observe that these countries have improved their oral health, but also they have been able to do it due to their higher income when it comes to their numbers as well. And right here, I want to show you a study that we have about the comparison of the inequalities in losing of teeth in different countries. They had me participate from Chile with Australia, New Zealand, Canada, and the US. The first that we can see right here now is the education level of socioeconomic inequalities, and how here in Chile, being the lowest, we have 59.98% of our lowest education level, which is basic education, even those without education, in comparison to the education that is higher for other people in the other countries. This correlates to what we can see in the mouth when we see to the mirror of each country. In each of these countries, you can see the gradients that exist that have the prevalence of less than 21 teeth in these 5 countries. But these also the prevalence, as you can tell, we can see the prevalence of cavities that are not treated in these 5 countries as well. And as you can tell, Chile has been able to increase that and or notice that it has an 80% of prevalence with the cavities not being treated. These results, when they evaluate themselves with the community, it's very important to notice that the inequalities, but even then you can also have to notice the very focal points that are happening in these areas, the inequalities of the experiences and experiments that have been happening. This also will be able to notice the access to the resources that these groups are experiencing that are unfavorable to them, on how to amplify the access and the disponibility of the medias of prevention in regards to that. Another date that I want to show you as well is these studies that like I was commenting earlier, are the cases of that provide information to us of what's going on with the oral health. And as you can see right here, we have the prevalence of 1 or more teeth missing or losing them is being affected. The groups of ages that are lower socioeconomic status at the time of birth in comparison to those that have a higher socioeconomic status at birth between the ages of 26 and 38. There, as you can tell, exists a trend that goes marking the points where those strengths are in your ability to be able to have a better socioeconomic status. The inequalities of health of social inequalities in health have the differences of health in individuals of different specific groups that are their social differences, for example, the socioeconomic. But I think also in regards to this, we also have to be able to go up and find out need to find, the different studies that we need to do in the researches as well. But we also noticed that with the inequalities, I wanted to share with you that we've noticed here this concept of social determination and determinants at a global health, but also, and here in Latin America, there have been a thought that has been surging up that comes to the health of a process. With these thoughts, we wanted to erase the health as a factor, but more of putting it on the relationship with everything else in the process of health and sickness. And so in the mark of these relations between the accumulation, property, and power, that would be able to help with the inequalities that exist. But those will also help with the process of those two and the relationship between the two. The evaluation of this studies of these social determinants that did the part of this determinants of the social determinants, it does something more complex than that of the factors of political, social, and economic as well. But it also helped us participate in this investigation that would show the inequality or equity help of those with the women in Colombia and Santiago, Chile, and Bucaramanga and Medellin, with the woman in postpartum. With this, as you can tell, that there are problems with social issues, the diminution of the people or women, I should say, that have younger siblings or kids, the machismo, the factors of violence against men or women, but also during the pregnancy of a woman during that time frame. One of the additional concepts that we have that we can name that is important or relevant to the inequity of oral health and the social health that affect the social health is to give us an account that for a very long time we had a very long centralized point of the bad habits could be the cause to all of these issues in the older generation, but also not noticing that these different aspects are also caused by the previous or older previous generational items that we have been doing. But these have been able to also cause a negative effect within our communities to generate that it also helps with the controlling of the odontology and causing them to be able to help with that as well. But it's causing us to also exhaust all of our resources to share the other items as well. So now we have talked about what worries us in the inequalities of health. And so these will help us with the gradients of why they worry about us. And so like Dr. Garcia says, those that are predisposed to these, it doesn't also mean that they're going to be the ones that happen, but also it'll cause them to have that social economic structure of being able to receive the care that they need in regards to oral health, but also with the illnesses that come with it. In regards to coverage, universal coverage or universal care or the right to health, it is with our social and oral health aspects. When we use the term of global health or universal health, and here we can tell that at a global level, the differences are less in regards to the systems that have come with other directions of the system organizations as well. When the global health coverage exists, it is very limited to prevention of universal prevention, but also in certain areas, it could cause the urgency, surgery, obstructions, or others, or also in groups, vulnerable groups.
Y la cobertura en salud es
and the coverage of health as well is lower in other countries. In Colombia, it's about 7%, and then Chile is in about 3%. And to be able to share with you these positive findings that we find, the political and the social programs and health programs that we have that we're trying to advance to help with the coverage. The first one is the explicit guarantees in health, or the GES in Spanish, which was created to be able to reduce the inequalities in health, but also ensuring that they have access, quality, opportunity, and financial protection of the people who require the attention, no matter what their co-payments are, and it's all for everyone. The second one is the Zero program, or Programa Cero, which is an initiative that would help to change the fundamentals, the management of the oral health in regards to that public sector area. These are from starting at the age of 6 all the way up to 19 years and 11 months. It includes a check on their dental, but it also helps with all of that. The paradigm change at the end is from a focal point in measuring the retention of their dentistry aspect of their mouth in high rehabilitated or pretensions of the evaluation to the percentage of the population that is under control. This is also in regards to their cavities as well, and if they have higher or lower cavities as well. The last message I have is that we need to be able to increase the access to health, oral health, but without having to pertain for anything else in regards to quality and opportunity of being able to obtain that, but also having an access to health access with the focus on promoting and prevention of the oral diseases with integration to the general health, and also making sure that they are being taken care of during the rest of their life. And my message for the ODS redactors is, does not exist a general good health without a good oral health. and that they need to be able to concise all of this together in 2030 to also include factors that also will include the oral health.
Gracias por su atención.
Thank you for your attention.
Thank you so much, Dr. Iris, Dr. Espinosa Santander, for your wonderful intervention. So the next presentation is going to be in Spanish. Our speaker is going to be Dr. Rosendo Rojas. He holds a Bachelor of Medicine from the Universidad of Cuenca, Ecuador, Master of Medical Sciences, and doctoral degree in Global Development Studies from the School of Economics and International Relationships of the Universidad Autónoma de Baja California, Tijuana, Mexico. Currently, Dr. Rosendo is a professor at la Universidad Autónoma de Baja California, Tijuana, Mexico, and adjunct professor at other universities in Mexico. Dr. Rojas is an epidemiological research advisor for hospital certifications at the Obesity Control Center in Mexico since August 2014. Let's welcome Dr. Rosendo. Please also follow the advice we gave you about interpretation. The talk is going to be in Spanish. So if you're a English speaker, please, just speak English. Thank you so much, Dr. Rosendo, for being here.
Muchas gracias. Vamos a compartir una presentación. Bueno, es por parte de la Universidad Autónoma de Baja California.
This is in regards to the Autonomous University of Baja California. Thank you so much for having me here with you guys. I will be trying to make sure that I'm within time. The themes that we're going to be speaking about in this talk will be about the inequalities in the world, the coefficiencies of Gini, the income, their employment, their attention to health. We will also talk about that afterwards. The hope of life as well. And then also the quality and health, the access to oral health, the attention to the in poverty attention, and then also the inverse attention, and then also the challenges for the access to oral health as well. And also the access to general health as well. First of all, we need to know that we live in a world that is very big inequality. We live in a world that models economic and political permissions and that promotes an irrational accumulation of the richness in less hands, which this phenomena is also a consequence of the social, political, and cultural that has been created with the conditions of these populations, which is also the 99% richness of this community. And also the 1% of the richness that we also have to talk about in that regards. And so those are the people that we have to present or concentrate on those that are rich. So when we're talking about the coefficient of Gini, we also need to be able to talk about the countries that are closer to the years that there was less inequalities, the same, that the income will be closer to that there is a higher inequality, excuse me. In the continents of Canada, as you can tell, they have, in other countries, they also ask that
mayores ingresos y el 60% tiene menores ingresos.
And as you can tell here in the United States, it has a lower income level in comparison to Mexico and Colombia. But here in Brazil, as you can tell, the proficiency is going down. With the Mexicans, it's only 45%. We have bigger counties with countries in Latin America, which is Colombia, and which has also diminished them as well. And then also the changes of political and social economics in that area as well, and Brazil too. As you can tell that they're decreasing at the moment right here in 2030. And then after 2020, as you can tell, everyone.
Puede disminuir un poquito la velocidad porque es difícil para los intérpretes.
Okay.
Muchas gracias. Bueno.
después del 2020,
after 2020, these inequalities have increased drastically. One, because of the pandemic, but also because of the issues that have been caused by the pandemic, but also because of the items that have happened as well. To be able to exemplify the incomes that we can find, the OECD, their Better Life Index, Index of Better Life that we have right here, of different countries that we have right here, that can tell us that those that have it right there, or the ones that are closest to them, are the better incomes, which means that they have better income, that they're able to satisfy all their needs that they have and have a better quality of life as well that they need to have. So as you can tell, the ones closest to zero are also the ones that have the closest inequalities when it comes to health. South Africa is one of the countries that it has the least inequalities of it. And then Colombia, Brazil, Costa Rica, and then Mexico are also the ones that are found at that lower numbers. And then Lithuania, Turkey, the Russia, and then Chile here as well, as you can tell, is another Latin American country that also causes them to be at the less. And those are the ones that have an extreme inequality when it comes to social health as well as oral health in regards to their employment, that are not able to satisfy their needs. But then in regards to employment, closer to 10 that you are will allow you to have better benefits as well. But those that are closest to zero as well are the ones that have less properties or benefits. And as you can tell, we have Brazil, Costa Rica, Colombia, and then Mexico, which are the Latin American countries that are closest to zero. And so 50% of the population has the pre-charges of having them, that the employment is not being able to give them what they need in a socioeconomic sense, as well as being able to provide them with that. In regards to the attention to health or being able to access health, in the countries that those in the third world countries, their attention to health has been in crucifix in a sense to the government. They are not able to help out with being able to give them access that they need to that health. They're able to also not have the capacity to be able to respond to the issues that are existent, or even be able to help those that are emergency problems or issues that may occur. And also, and because of that, and what has been spoken about in the past, there does not exist a system of a health system that will guarantee the access or even be able to accomplish being able to have that access as well, that can guarantee the coverage of those distinct problems of health that they may suffer. And so those will also cause to the effects that I may have or the issues that I may have when I go into the doctor. So then what will happen in a lot of countries is that the access is not guaranteed, or that it is guaranteed to certain aspects of it. And so when the patients are not being tended to, there is that big distinction between the two. In regards to Latin America, they have an inversion of health that is minimum, which gives them a possibility to be able to, that will show the fails that they have of the system. And so the people are not able to access the health care systems. And so they're obligated to find those services somewhere else. And in regards to health expectancy of life, which also is an indicator of this, of how good the system is in regards to a country. As you can tell right here in observation, that the health expectancy or life expectancy is Colombia. Mexico has maintained a good level right here. As you can tell, it's maintained the same, but then Canada has increased as well over here, which have been able to satisfy the health systems or the health needs of their population needs as well. So their health expectancy, their life expectancy, excuse me, is higher than that as well. Countries like where you're able to find a lot of these populations, like in El Salvador, where there haven't been able to do much increase or differences in their life expectancy. They've been able to somewhat increase it a little bit, I guess. In regards to the quality of health that they receive with the OECD, with the Better Life Index, this will talk about how well their health is, or the services to their health is. And so this is also to satisfy the need that they need for health care access. And also we'll talk about the pathology and the health care access that they have. So Russia, South Africa, but then again here, as you can tell, Mexico in this case is 5%, which is 50% of the cases have been resolved with the solution. And then after that, it's Brazil, and then Chile. And then Brazil has come to about 6.5, a little bit over 6 for Chile. And then that means that 6 out of 10 patients that have received any kind of treatment have been satisfied with it or have been helped with what they need. The problem with the access to oral health, in almost all of the countries exist a mixture of offers when it comes to the dental access or attention to dentistry, the public sector and then the private sector. There are very little places that you can go to when it comes to dental care. So it also costs, depends on the cost and how long it takes to be able to be seen. In the public sector, it's very limited. The times of waiting is as long, and then there's extra cost to that intention as well. So here, when I try to go to the public health sector, when I get access to that, sometimes it has to already been solved, or I need to wait a long time to do that as well. In regards to the private sector, they have higher cost levels when it comes to the attention, but they also are found on above the income of the middle class. And then a lot of their pre-cavity attention will depend on the cost that they get as well. So like in my family, like if your family has 4 members of the family and you're needing to get the attention for them, then you'll have to base it off of the 4 members of your family. But then they also have very high level of cost when it comes to all of their cavities attention. But you're not able to satisfy your healthcare needs that you need. In these 2 statements that we have right here, it's very important for us to keep going on. The access to the services of oral health in public exists a higher demand or a limited demand, excuse me, in regards to an unlimited offer that they also have for everyone else. Because the demand in the public sector seems to be very limited. And then the services of the oral health in the private sector exist a unlimited offer and before having a limited demand as well. So for this one, it's more money wise. The more money you have, the better access you have to be able to pay for that as well. That you're able to access those services. So the public sector creates such a big gap when it comes to their groups of attendees. So that causes them to be able to have that differential between the middle class. And they have not been able to access the public health sector that will satisfy their needs. And so they have to go then to a private sector to be able to get the offers. But then they have services that are unlimited, but then their demand is limited, and then the payment as well, there's cost is very higher depending in comparison to the public. There are also 2 very high paradigms in the oral health access, which is the poverty attention to it. This one is also from 2008. With attention to the World Health Organization, that they are able to explain this better, saying that those are the people that are not able to access this health, but they need to be able to access those public health records or not activities, but their care is based off of what their income is. And so due to this, there is a missing of services or not being able to get them services in regards to the public health because they don't have the services, excuse me, that amplify the treatments that they need. And so the persons are obligated to then require to go to a private service, which then the costs obligate them to have to waste more money or spend more money from their incomes than what they are able to live in those conditions. And so this causes them to live in conditions of transitory poverty or permanent poverty because of due to their health as well. So this is causing them at a global level as well. But according to the World Organization of Health, to the World Health Organization, approximately 100 million people have to live in these conditions of poverty at a global level because of that. And those are due to the failures of the public sector as well. Also with the attention and the paradigm to the attention of the inverse, in these sectors, we notice that the community also are they are not able to access them. And so these are the ones that have been able to access them at a public sector, but also in comparison to negative private sector as well. And so with the attention, and so this is a comparison to the communities that are able to attend or receive those health attentions in regards to those that have to do it with oral health. And so those that the people that have less access to those oral health services are the ones that definitely need it more than anyone else. And to the oral health access in Mexico, the understanding or the knowledge is that there is a limited services being of the principal factors having the access to private sector. And so the access to the health access to it is very high in regards to it, but the cost is high, and then it causes the person to not have to be able to find what they're actually needing. Also, in the particular case of Tijuana and Baja California here in the Autonomy University of Baja California, we have been able to provide those services for oral health, general oral health of the specialty at lower cost and of higher quality, which have been able to help substantiate in part the missing offers of being able to give that public health. I am ending up right now. The challenges to access to oral health. So the systems that have been able to obtain that public health have guaranteed access or coverage universal for them, but then also have created public politics to foment a good practice of oral health in that sense, but also have thought in systems of the health and the laws that have been created because of that. To think that the health systems have been able to adequately change social changes and also advance in the coverage and the quality and also the infrastructure that comes with that. But to the year 2000 are the health incomes that, or health systems, excuse me, that have been able to create and access the patients, but also be able to give them a better quality of life. A very important quote that we have right here is that by Deaton is the biggest escape of history is the escape of the poverty and the death. For thousands of years, those that have the luck or have been lucky to escape the death in the child have been able to battle or go against years later of oppressive poverty. So it's saying that even if I don't die of death as a child, I still have to be able to confront years of oppressive poverty growing up because of the reason of that. Thank you for your attention.
Muchísimas gracias, doctor Rosendo, por su excelente presentación. Ahora tenemos otra.
Thank you so much, Dr. Rosendo, for your information that you have provided.
Now we have another speaker. Thank you so much, Dr. Rosendo. The following.
El siguiente será en inglés.
Dr. Beck is a medical doctor and clinical professor in the Department of Family Medicine at the School of Public Health at the University of California, San Diego. Since 2018, she has been the Faculty Director of Leadership and Faculty Development for the University of California, San Diego. She is the founding director of the University of California, San Diego student-run free clinic project, whose mission is to provide free, high-quality, respectful healthcare to the underserved population while inspiring the next generation of health professionals. She is also a member and former chair of the Medical Children's Health Advisory Panel. Dr. Beck is the founder and director of National Faculty Development Programs. I was part of that program. The name of the program is Addressing the Health Needs of the Underserved. I was one of her students a while ago, which with this program, she had trained more than 300 medical and dental faculty members since 1999. This program has led to the creation of more than 25 new student-run free clinics, as well as helping to create both student and faculty national associations of student-run free clinics. She also created a clinical fellowship in underserved healthcare at the University of California, San Diego, which was the first in the United States. Let's welcome Dr. Beck, and thank you so much for sharing your experience and knowledge today.
Well, it's truly an honor to be here. Es un honor. Gracias a ustedes. And it's particularly lovely to be here with this beautiful program that Lily, Dr. Pinzon, is creating, because she's been a source of inspiration to many people that I know. So we'll be talking today about inequities and inequalities. I was asked to talk about oral health in the United States specifically. So that is what I'm going to do. And I'm going to appreciate my previous speakers and have the courage to say a few things that while I was listening, I'm thinking, should I really say these things? But I will. So this is a little bit, just some of the topics we're going to cover. I'm not going to go there. What I'd like to start with is a moment of gathering. Let us gather ourselves within ourselves. It's the end. It's perhaps for some of us a long day, a long few years. The world is weary. We are facing so many challenges at the level of the world, whether it's war, whether it's illness, whether it's the profound inequities, and in our own families, in our own homes, in our own communities. So I invite you to go within yourself for a moment and just pause for a moment and appreciate yourself just for being and for caring about things like justice, about the well-being of people in the world. Just say thanks to yourself for being. And then I would like to respectfully acknowledge the ancestral and unceded territory of the Kumeyaay people who have stewarded the land on which I both live and work throughout the generations. So this was what we were asked to do, to look at these access issues that determine inequities in oral health. So I really tried to think of what is causing such profound inequity in the United States. And we're going to look from where we are to where we would like to be and some of the true obstacles. And then in the next session, it will be about what will it take to get from here to there. But today we're looking at the problems. So this is a family that I took care of in the free clinics that we run. You can see the abuelo and the abuelita and one of their nietas. Beautiful family, a grandfather, grandmother, and their grandchild. This couple who lived in the United States were raising 7 American citizen grandchildren, but they themselves had absolutely no eligibility for access to medical or dental care. She had kidney disease, he had heart disease, and we were honored to learn from them and help provide care to them, both medical and dental. So the WHO, the World Health Organization, as others have said, says that health is the presence of a state of well-being. The Institute of Medicine has recognized that the United States is one of the few countries in the world, industrialized countries, that does not guarantee universal access to healthcare. In 2000, David Satcher created the first report on oral health in the nation and recognized that more than 108 million people in the United States lack sufficient access to dental care. It was a wake-up call. And the question is, are we awake? And sadly, I think we've made some improvements, but in many ways, the answer is still no. So this is the summary that I would normally give you it at the end, but I'm also going to give it a little bit at the beginning because you'll see, and then I'll give you the data that matches these things. But of course, this is not everyone, but it does represent many. So what are the barriers? Well, the business profit motive is a driver for many insurers and many in dentistry. The political power of organized dentistry protects the income and autonomy of dentists when there are attempts to make it a more universal access. Many people in the United States fear social responsibility. They think it will lead to loss of freedom rather than gain freedom. And the United States has not been ready to define healthcare as a human right. How can we have life, liberty, and pursuit of happiness without health? I like to think of underserved dentistry rather than poverty or charity dentistry. We as a nation are underserving huge segments of the population, and there should be a right to healthcare. And then we know that there's prejudice and intolerance towards elders, people of different ethnicities, those with special needs, profound lack of cultural humility in many groups, not in everyone, not in the people on the screen, not in many, many people, but in others. And then there's a lack of knowledge, navigation, both for providers and also for patients. Something I like to call false access versus true access. And then who is looking at quality and outcomes? Are we really making a difference? So I thought I would explain to you how people get healthcare in the United States, because it's so complicated. If you have no papers, if you're undocumented in this country, no official papers in the United States, of course people have papers, you don't get anything, except in California, where the laws have recently changed dramatically and wonderfully to improve access to care for the undocumented. But in the rest of the country, you might get emergency services, a bill that creates debt. You might fear debt, or that if you take government services, maybe you won't be allowed to qualify to actually immigrate. People who have very low income qualify for something called Medicaid or Medi-Cal, depending on the state. But we're going to look at a map in a minute that says which states do what. If you're low income, you're earning too much for Medicaid, you might get Obamacare, but Obamacare has no dental coverage. If you're mid-income, you might buy insurance through Obamacare. You'll still have to have additional purchase of coverage to get dental care, or maybe your employer gives you some. And the insurance you'll get will be very limited. There'll be a limit, generally even with very good dental insurance, it might be $2,000 over a year. You'll still have to pay more than half of your services and all lab fees. Private coverage is very expensive. Dentists negotiate with the American Dental Association to have a final amount that people pay, and it's often based on the zip code of the dental practice. If you're over 65, you get Medicare, which is a very good healthcare system, but there's no dental care involved, zero. So let's look for a moment at elders. 68% of people over 65 have gum disease in the United States. 20% have tooth decay, which is not treated. 20% are dentulous. They've lost all their teeth. And of course, oral cancer is common. Only 29.2, 30% of people in the United States over 65 have dental insurance. And for Hispanic adults, that's less, 17.5%. So we have serious problems. Here's a wonderful elderly person who we took care of. So I want to show you this map. On this map, you see the states of the United States. The dark blue is where there's reasonable access to care for people who have Medicaid. You might get some decent dental services. The turquoise, limited services. Maybe some prevention, some treatment, you have to pay the rest. The dark yellow, only emergency. The light yellow, nothing. Because healthcare in the United States is state by state, county by county, and actually zip code by zip code, which makes it incredibly hard to do anything on a national basis. The next map shows you the difference between reimbursement. Like in California, on the far left, it's dark blue. You'll see that in California, dentists who take Medi-Cal still receive 90% of what they would have billed if they were in a private office. But if you're in Oregon, the light pink, a dentist in their private practice who took a Medi-Cal patient will only get 40% of what they would have billed. So the American Dental Association says, therefore, we can't afford to participate in Medi-Cal. The next slide shows urban and rural. It's a little bit complex. But if you look at the dark purple, that's where in urban areas, there are not enough dentists or dental hygienists. There's not enough dental professionals. If you look at the dark green, those are rural areas where there are not enough dentists or dental hygienists. The white areas are where there are enough. So this idea of false access versus true access. Well, only 38% of the American dentists are willing to accept Medicaid. So even if a person has insurance, this low cost, insurance for people who are low income, there are not enough dentists, or there are not enough dentists who will take that insurance. So then to me, that's false access. This is a study of dental students, because clearly some of the changes we want to make, we want to see things happen in the in the university. Over 3 to 4 years, students who their willingness to treat low-income, frail elderly, homebound, and not English-speaking populations decreased. Dental school was an intervention to lead to less interest in caring for these populations. Now, there are some buffers to this, community-based experiences, role models, but in general, this is not only the trend we see in the dental world, but also in the medical world. Dental graduation, half of graduates will enter private practice. Dentists from students who graduate from underrepresented minorities in the health professions are more likely to work in federally qualified health centers or clinic groups. 40% will enter advanced training. Of interest, on the dental graduation survey from the UdeA, there's no question about asking whether they're interested in working with underserved communities or whether they plan to. And we talked about the issues of medical and dental integration, that there's very limited education in dental and oral health in medical school, that medical students graduate with very limited knowledge of integration, and that needs to change. So healthcare is a human right. Well, we haven't got there yet. It's not seen as a right in the United States. And we talked about this. That social responsibility increases individual freedom, but many people in the United States don't believe that, and they fear loss of freedom. And the media often provokes this. In the Congress, there are 4 members of the House of Representatives who are both Republican, conservative, and dentists. And they constantly advocate for less regulation, less tax, and more autonomy. Twice in our history, at least, when Medicare was brought in and when Obamacare was brought in, there was a desire that dental coverage would occur. But both times, organized dentistry said, no thanks, we'd rather go our own way. The ADA has spent more than $2 million in lobbying in last year. They were very happy that they successfully advocated against expanding Medicare to include a dental benefit. And they worked to prevent insurers from dictating fees. So the ADA isn't all dentists, and many dentists believe in social justice and change. But the energy of these predominant organizations is against universal access to care. We're not going to talk too much right now about prevention, but there's tremendous need for work in prevention. Orthodontics mustn't be a luxury. It's part of health, and how do we gain access to it? If we had time, I would share this sad story of seeing a child who had braces put on by an orthodontist, but when the family couldn't afford the cost of the care, the orthodontist refused to remove them. So then the teeth went in the other direction, the child's teeth, and we removed them, but it was tragic, actually. And then these are some of the things. I can't afford to pay for dental care. I can't find the office. There was too long a wait. And we talked earlier about the increase in diabetes prevalence in the country. This is 2017 on the right. There's an enormous need for integration of care. Also for mental health involvement. Many dental professionals don't address mental illness when they're working with a patient. This is a wonderful patient of ours. Children, serious problems of tooth pain, work in schools. Not all children are eligible for care, but mostly in the United States, children are eligible. And then I like to say that toothlessness leads to joblessness. A study that was done showed that when they used these different variables, the discoloration of the teeth was one of the main factor with whether 2 people of equal qualities which one would you hire? And people, when the person had discolored teeth, they were much less likely to be proposed for hiring. So our worlds are often separate. We need to bring them together. We must think about underserved dentistry, a right to healthcare, and that we are underserving populations. As a nation, we need to wake up and let go of our fear and really stand up and say, oral health care is a right. How do we achieve it for everyone and not succumb to these profound political pressures not to do it? Things like education and fear and transportation are all very, very important. But even if everybody had complete education, they wouldn't have increased access. So we need to work towards change together. These are some useful websites and books. This is one of our favorite patients who is a great teacher for all of us. I want to thank you and just think about, you know, what Gandhi said. We must be the change we wish to see in the world. And in order to do that, we have to do what Bob Marley teaches, which is to emancipate ourselves from mental slavery and free our minds, and then do what Martin Luther King taught, which is that injustice everywhere is a threat to justice everywhere. There are many injustices here. It's an honor to be part of working together towards change. Thank you.
Thank you so much, Dr. Beck, for this wonderful presentation and sharing, you know, your kindness, especially, and you know what I'm talking about. Okay, so now we want to open the forum for some questions. Okay, we have one long comment and question that I'm wondering if Yesenia already has it. Colton, could you let me know if you sent the question to Yesenia?
I did send it. I haven't heard back yet.
Okay. Well, I can read it in Spanish and English, maybe.
Mm-hmm.
Yeah. Okay. So, I don't remember. ¿Quién fue la persona que la?
Estela C.
Estela C. So, Estela C preguntó lo siguiente. Adicional a los determinantes de salud, los factores sociodemográficos y sistemas de salud fragmentados en toda la región, se ha encontrado en algunos países como Brasil, Colombia, una relación entre centralización del talento humano en salud oral en las grandes ciudades, dejando a un lado las zonas más apartadas y vulnerables. Ella dice, mi pregunta es, ¿consideran ustedes que es necesario involucrar los profesionales desde la práctica privada para aumentar la cobertura de la atención en salud oral y contrarrestar el impacto, esta brecha en accesibilidad en la atención y disminuir la brecha causada por la centralización profesional en odontología en las poblaciones más vulnerables y apartadas en América Latina?
Perdón, esta pregunta la hizo Alejandro, me parece que
Alejandra
es
Sánchez.
Alejandra Sánchez, sí.
Bueno, ahora lo voy a leer en inglés. In addition to health determinants, sociodemographic factors, and fragmented health systems throughout the region, a relationship has been found in some countries, such as Brazil and Colombia, between the centralization of human talent in oral health in large cities, leaving aside the most remote and vulnerable areas. His question was, do you think it is necessary to involve professionals from private practice to increase the coverage of oral health care and counteract the impact of this gap in accessibility in care and reduce the gap caused by centralization? Professional in dentistry is the most vulnerable and remote populations in Latin America. Who wants to answer? ¿Quién quiere contestar?
Si quieres, Lili, podemos leer las respuestas que habíamos puesto ya en el chat. De hecho, los tres habíamos contestado.
Bueno, si quieren, lee cada uno la respuesta. Maybe each one of you can read the answer. And I want to know if our interpreters are still online. Seems that they're not.
Yep, nope,
Sí,
they are. They just wrote
Yesenia,
in the chat.
Okay. Okay,
están en línea.
so maybe they can answer, they can you know, interpret what the speakers are going to say. Okay, thank you. So Carol, you want to start?
Bueno, sí, yo un poco respondí apoyando lo que había respondido primero el doctor Rojas, porque pues él menciona que el tema es que alguien tiene que pagar los servicios, ¿no? Digamos, alguien tiene que pagar por esos servicios.
Has to pay for the services. And so I mentioned that there is an impact with the inequalities, that you have observed that those services have universal coverage. So it's only for some certain groups, the universal groups, they have the financial public or financial assistance public-wise. And so that helps with the minors as well. And also with the various analysis, and also with the focus that is on the primary side. But then the characteristics also help with the services with the oral health, with lower levels of health as well. So that helps too. Thank you. In the part of the attention to the oral health, someone has to pay for them. And so for those that are paying it to the services, that the debt goes to the user or to a third person that is not able to maintain it during that time. And so we're not able to provide the services to help them with the access, with the universal access to them as well, or even access to them. And also the universal coverage as well. Yes, I can do that, but if the services can't help provide the services that I need, well, then that's also where the inequality comes. And so the two biggest pertinents to that is that the services for oral health to the communities that are farther away from the downtown area, with the dentist, like a capital or even like an agenda, or even like a village that's like 5, 6, 7 hours away. It's also, you know, that can cause them to have the consensus of being able to be gone with the private health organization as well. And so this will help be able to separate from the profits with those to the health access, but also to help provide with that, because what they're trying to do is earn money. Their profit is to gain money. And so it's not helping them to be able to improve the access to health access, but the private sector is more than anything to gain money or to earn money. And so in comparison to that, the avalanches of them is that they have to strengthen what it is the aspects of all of the health care system in the private sector, with the attention that they need to give, the education, prevention, and then access to it. But then also after that is to the rural level, subsidize some of the programs that will help with that. Lily, I would like to add, I agree with the responses, but mainly then I think it's just to focus on strengthening the best results, to focus on the preventative health. And also with that, yes, every country needs to be able to take their own decisions to what groups, age groups, or in regards to how many of those family members also are able to go and advance those healthcare access. And so then, in my opinion, there should be a very strong focus to the preventative care for all age groups, on all groups, no matter what, pregnancy, women, kids, you know, adults, third age, like elderly, for all the population. And then our next point would be that we'd have to focus on the problems that are now already been there, but be able to help with those, financially, be able to help them out as well. Also help them in the situation of the poverty, and also recognize in other countries, immigrants as well. That would also be it. The other point that I also wanted to clear is an experience in Chile that would favor, able to diminish the inequalities in the system, is for the medicals and dentists, is also a account that will provide them a number locally or annually that will be able to go to rural areas that will be able to provide those services to them in those cities. That would permit them or give them the ability to be able to go to those areas, rural areas, to help. But then also those also have to be a decision from the government. Because like in Brazil, which is even a higher country with development areas, and so those areas, those countries.
So if, am I next or?
Yeah,
Yes.
Rebecca, I was going to call you.
Okay. Just checking that. So I actually think it's a very good question. And I do think we need to work with dentists, physicians in private practices. And there's several aspects of that. One is, how are we doing our education when they're in school? So that the doctor who is out in the community in a rural area or in a remote area not only sees as part of their responsibility to do some of this work, but maybe gets to take students from the school that they went to. So it becomes part of the training and the role modeling that and maybe some of the cost of the training is defrayed if you see patients out in the rural area or in a more remote area. You pay less when you go to dental school, for example. So I do think that there's, and then in the community, the other possibility is rotations, so that you have a group of dentists in the central area that spend a month in different locations and then come back into the central area. So that, and often maybe you're creating this place where the dentist in that more rural area has a chance to have a few weeks off because it isn't the only dentist in that community. So I think there are really wonderful ways to collaborate, but it has to do with working on the mindset of the actual health professional in order to achieve some of those changes, and then support that when they want to make a change or do more pro bono work or support it.
Perfect. Isabel, do you want to read the next question, please?
Sí, claro. Vamos a ver.
Of course, let me see. The second question says this. It's from Estella C. I would like to ask if one of the panelists have realized the studies of epidemiological within the work area and the impact of the oral health, or how that is able to prevent them with oral health. These diseases are. That is the question. Yeah, no, I'm gonna write it now, but right now, me particularly, no, I have not. I haven't been able to do these studies, but I have had various references that I've with this and interested. And there's a lot of studies that show this, and this idea that in this characteristic of social work, of imbalance between strength and compensation in the laboral sector, work sector, in regards to oral health. And so it's a psychosocial analysis aspect that is frequent, that was also very much with cardiology, and then also with the starting of making those changes or doing the stages of them as well. There is a doctoral thesis that is also talking about this theme as well, about the different aspects of the laboral area specifically, and then also imbalance, strength, and composition in the laboral aspect. But it's worth mentioning that it's something that we need to explore because there's a lot that we need to do and explore in that area of characteristics within the sector of labor. But on the other hand, as well, there's a group of studies that will explore the inequities of laboral health and question. It's more of the conditions, and is what they're asking about here, but with these analyses as well. So I think that is a good point.
Ok, tenemos otra pregunta.
Lili, disculpa.
Sí.
¿Quieres responder algo pequeño a...
I wanted to respond to Estela as well.
No tengo experiencia
I don't have experience in that, in the laboral conditions, or in that aspect of the oral health.
Tengo antecedentes de
I do have history of colleagues in Chile that have worked, and this has also taken to a conference that is related to this, but it's not this. So when you design programs that talk about children, so like with the kindergartens or like schools, it has shown that teachers that work with those students also need to have access to oral health and health, because that will help them also to be able to be the ones that take care of it, but also be able to take care of the children. Codependency, but also requires a attention, a dentistry attention for these programs, so that includes the care of those that are responsible for the education. The importance of taking care with the caring of the oral health, it's responsible for those that are in charge of it. And so it's something in relation to work, but it's also something that we should mention. It's related, but not exactly. For Estela.
Anyone else wants to say something about this question? ¿Alguna otra persona quiere decir algo de esta
Something
pregunta?
else, someone else want to answer or ask this question, or we should go on? Okay, then the second one.
Esperen, yo la encuentro. ¿Cómo podríamos enfrentar las
How is it that we can affront the inequalities that while we are, how can we face the different inequities in health while we are within an unstable government? I can do it. I think that in political instability, it'll be more of a technical issue, not really a political. And so politics should not be strong, that can long and resist, that is those that have an unstable government as well. So it's more of a technical situation of an inconvenience, a greater inconvenience. But it also comes with the politics that come about it in our governments. The politicians move what is best to their necessities. But yes, but if they end up to going doing something more technical political, then without counting the government, then it'll become an embattlement. Well,
Yes,
I
right.
can go.
Oh, go ahead.
No, you go ahead, Ellen. Sorry, I didn't see your hand up.
Bueno, so I think that there's various things there. One, I'm not gonna, and I didn't show it in the presentation, but there's strategies that work in communities at distinctive levels. So of course, we have the studies. The higher the changes are, the impact is greater because of the structural changes there is. The further back we go, then that means that's also we're going to go, the determinants will be higher too as well. So the changes are higher too. But we're able also to work on different levels. And another thing is also that in the theme of power, and the power of being able to make changes, the social economics as well, it's not to our power as well, but it's also, we're able to do it too. It's, in this positive area of socioeconomic, the capacity of being able to exercise, the ability to be able to move. And so those changes, it is a tool that we have that is not bad, that will make us self-sufficient professionals. And so it's like we need to explore these distinctive mechanisms, but that power that we have to be able to academic wise but also be able to maximize them which is most important, which is what we need to be able to say, which is what Lisa Cordova says as well, is that we have the option to utilize the movements as well and action as well for that changes to happen. But we'd have to think about that as well.
If I can say that, I don't know, one of the things that I think these are another very good question. The changes that we see in the United States, I mean, it's like every 4 years for people, the rules change completely. And so dental care has been something that has been very sensitive to whether states cover dental care or they don't. Changes like whether, and so it's very confusing for people because this year it's okay if I receive care from the government, I won't be reported to the government, and next year I will be. So how do we create continuity is a really good question for some of these policies, that continuity that is sort of protected against these rapid governmental changes and political changes. And I think it's very hard. It's very hard. And I know it's extremely confusing. So there's a real place for education to say, you know, this is what you have now. And it would be beautiful if we just saw a change that was just always improvement, but that's not the way it works. It goes, you have this or you don't have this. And it makes it very confusing and fearful for people. Can they go and get something they're not sure what it is? So I actually think there's an important place for education, but thinking about continuity in terms of these UN goals, thinking how do you establish continuity for some of these principles?
Very well, we have another question now. From Mauricio Rodriguez. What explains more the persistence of the chronic diseases not transmitted, like the predental diseases, or like does it focus on the determinant of social economics or the determinants of the inequities of social contexts as well as economic and yes. I can start. So in general, it's not focuses contrary. I think they are implemented with the ones that we need to do. And I think that they are complementary as well. With Latin American countries, the inequality, it's again dramatic issues, but it's also it's an element that methodological that causes these, which causes more strength as well. That is also explaining these as well, and they complement again very well these propositions, because of initially they are the ones that will help with that. And so I think that it's the synergy. That would be my opinion.
Doctora Santander Espinosa.
Thank you, Isabel. Yes, I agree with Carol. The problem is that historically speaking, the odontology was not preoccupied with the values of with the determinants. That's the problem, that it didn't consider that these were the causes of the cause of the oral diseases. So this was a theme or the subject that works in Zapopa, that this is, but the practice odontology wise, with the odontologist a couple years ago, actually, they didn't recognize it. They were the causing of the diseases of the chronic oral diseases is because of the behaviors and the individual behaviors of each. And so I think now we have hope because we recognize globally, but also within the odontology department with everything that's missing, or that they're recognizing everything with in regards to health that is helping the government, the ones that are in position of power as well. And so this are the oral diseases as well as with the oral health communities.
Gracias, doctora Espinosa.
Thank you so much, Dr. Espinosa. Someone else? Well, yeah, the determinants, yes, true. But the economy also is distinctive with the theories, with the well-being, because you have to try it, because of the basic capabilities that some people have with health, with transportation. Even from the beginning, to permit them or allow them to be able to give this or be dignified to live. And so it's very much so that these necessities, especially in the oral health, that the information, like they're saying, like Dr. Espinosa said, that there is not showing or teaching the students the prevention of oral health because it's so focused on the curing of the diseases instead of focusing on the preventative area when it comes to that, with the determinants of everyone else. But it tries to work with the determinants of health, prevention, as well as the treatment. And so that will cause those, but then also this might be one that causes them to be transmitted, consuming some. But then this is also something that we need to be able to show people.
Gracias, doctor. ¿Alguien más?
Thank you, doctor. Someone else?
Okay, I think we have a last question. Tenemos una última pregunta.
We have one last question here, okay? Do you think that the problem with the promotion and prevention of oral health is that the results are seen in long term? However, the health policies seek immediate results. Who would like to answer?
I think you always need to have short-term and long-term goals. Like as Carol said before, that the two have to occur simultaneously. I think that change in behavior around prevention is generational, whereas at the same time you want to address somebody's serious diabetes and help them from not dying. And then families start to learn maybe change is a good thing, maybe education, maybe taking public health responsibility is a good thing. So I think they go hand in hand as people experience change, and also are most vulnerable and are most ill. To ask to take on all these behaviors is a great deal to ask. And I think if people feel better and healthier, they can also work, like in the free clinics that we run, we see very serious people with very serious illness, but then they start to control their sugars and they start to eat healthier. And then we have them see the dentist and they're starting to take care of their dental hygiene. And then their kids come to class. And so change, I think they occur together because people start to believe that change is possible because they see the evidence in the short term and are willing to work towards it in the long term.
Anyone wants to add something else? ¿Alguien más quiere decir?
Someone wants to say anything else? Lily? Yes, I was actually answered this because it was a long term, because you have to be able to acclimate yourself to everything that comes with it. And so you have to be able to help with the groups that are injured. With everything else, I think it's important that we need to have the attention with our countries that when these programs are great, made to be able to help with the adults, with the treatments or integral treatments that they are spoken, that they have to be complementary with the control, so that the treatments that we have provided or provided in certain groups are able to have results at a long term. And so that's able to help them with good health as well. And so that's why, anyways,
okay, I think we're gonna close today the seminar. We appreciate your attendance and participation in the seminar and invite you inequities, and the topic to be discussed will be globalization and oral health. How does it influence America? Remember that the seminar can be viewed again on the YouTube channel of the University of Utah School of Dentistry. We'll be posting the recording session there. And finally, please remember to complete our satisfaction survey. We need your opinion to improve this wonderful experience. We will see you soon, and thank you so much.
Thank you, gracias.
Muchas gracias. Hasta luego, buenas
Chao.
noches.
Gracias a todos.
En conocerlos. Gusto en verte,
Saludos.
Carol.
Lo mismo,
Gracias,
Iris, un
buenas noches.
abrazo. Mucho gusto.
Un gusto conocer a Helen. Rosendo.
It was a
Rosendo.
pleasure.
Un gusto
Nice to
igual.
meet you.
Un gusto conocerlos a todos.
Un abrazo.
Gracias a todos, buenas
Buenas
noches.
Hasta luego, buenas
noches.
noches.
Todos buenas noches. porque
Gracias,
todos
Lilian.
estamos en
Gracias.
Isabel.
Hasta luego.
Chao. Abrazos.
Gloria,
Chao.
por la
Gracias.
coordinación.
Muchísimas gracias a todos por su participación.
Gracias.
Y gracias a
Buenas
nuestros
noches.
traductores,
Thank
Roberto,
you,
Ay,
Verity.
sí.
Utah.
And Colton, thank you so much,
Colton.
everyone. Thank you so much.
You're welcome to help. Thank you, everybody.
Thank you.
Colton, gracias,
En grupo.
Roberto y Yesenia.
Have a good night.
Grupo Inspiracional.
Muchas gracias,
Noche
Ellen.
para todos.
Gracias.
Chao.
Rosendo,
Gracias.
Iris.